And good afternoon, everyone. It is noon in March. Hard to believe that February has passed us already, and we are well into the spring season. Welcome to the Maternal Health Echo, which is brought to you by the Center for Substance Use Training and Telementoring Center, or CSTAT, at Be Well, Texas, in collaboration with the Perinatal Psychiatry Access Network, or PeriPAN. My name is Brenda Macias, and I am today's facilitator. To help us with attendance, we ask that you type your name, your affiliation, and email into the chat. To access the chat feature, you can click on the speech bubble icon in the navigation bar of the Zoom toolbar. If you're joining via phone, please email your phone number and name to cstat@uthcsa.edu. We do hope that you will join by video for the discussion portion in the latter half of the session. But no matter how you are joining us today, we're just happy that you're here to learn alongside us. We encourage everyone to unmute and share questions and comments aloud after the didactic, but we ask that you stay muted unless you are speaking. There's a lot of us in this space, so keeping our comments brief will allow others to share as well. And finally, please note that no protected health information is allowed in either the chat room, or in our discussion. Our didactic today is on postpartum supports for parents and will be presented by Dr. Emily Humphrey, a family nurse practitioner and maternal health echo hub team member. Following that, we will discuss a case presented by Dr. Ganji. We'll start with introductions of our hub team members. We'll follow by the didactic, then continue with announcements, the case presentation, and open discussion. Once again, thanks for joining us today. And we'll start with our introductions of our hub team member, Dr. Ruiz.
Hi, thank you all for being here. I'm Dr. Ruiz. I am a perinatal psychiatrist for the TTU HSC University System at the Texas Tech campus. I am also the regional director for the PeriPAN program in the West Texas region. Thank you so much for being here with us today.
Thank you, Dr. Ruiz. Dr. Subrin.
Hi, good morning. My name is Joy Subrin. I'm a licensed master of social work and a doctor in behavioral health. And I join you as a hub member from the University of Arizona, part of the Banner UMC system. I'm the dedicated social worker, behavioral health provider in an OBGYN clinic.
Thank you. Thank you for being here. I'm going to leave Dr. Humphrey for her introduction right before our didactic. Well, we welcome both of you, our hub team members. I know that we are missing a few hub team members for the Texas conference in San Antonio today, and we want to thank everybody here that is here for participating in today's session. Dr. Humphrey, we're glad to have you as a presenter, and we'll now hand this over to you for your introduction and presentation.
Awesome. Thanks, everyone. I'm Emily Humphrey. I'm a DNP. I am out of Waco, Texas. Now I was in Austin for a while, and I've spent the past 12 years doing homeless healthcare and addiction medicine on both the inpatient and outpatient side, and focused on women as well. So I'm excited to get started. Let's see, my slides will come up. I will apologize in advance. I am losing my voice, so I'm going to push through and hopefully you all can hear me. All right, let's get started. So today we're talking about postpartum support for parents. Next slide. Disclosures. No disclosures for me. All speakers and members of the planning committee have no relevant financial relationships, no interest to disclose, and the views and opinions expressed by the participants and speakers are solely their opinions and don't reflect any official position by UT Health San Antonio or Texas Tech. Next slide. Learning objectives. So first, I'm going to start by just defining the postpartum period, and that seems like that should be very easy, but there's a lot of different opinions out there, and so we're going to kind of wrap our minds around that, and then we're going to talk about some common postpartum complications, because once you know some of the most common complications, it helps you anticipate them and get ahead of them and prepare. And then I want to outline some strategies to help prevent complications and support those parents. And then at the very end, I've got some resources that I want to give you all that you could start using today. I wanted to start with a quote from ACOG because I think they say it well. To optimize the health of women and infants, postpartum care should become an ongoing process rather than a single encounter with services and support tailored to each woman's individual needs. I think it's really important for this whole presentation and for just caring for our patients to put ourselves in their shoes. For those of us that have had children, to remember what it was like in that postpartum period. And for those that have us that haven't, to use our imaginations, right? Because when we do that, we can really care well. These moms and dads, right? But especially for the moms, recovering from childbirth, adapting to all these hormonal changes, learning to feed and care for a newborn. And there's a lot of pressure on this time, right? We're told this is a happy time, this is a joyful time. And although that is true, I think sometimes that sentiment gets overshadowed with how difficult it can be also. And it can present a lot of significant challenges. And so really wrapping around these moms and supporting them and their partners is really crucial in that postpartum period. There's also a lot of pre-existing health conditions that moms might be having to manage, social challenges, and substance use disorders. So all things we need to have on our radar. Next slide. So postpartum period. So, I mean, if we break it down, make it simple, post just means behind, right? And partum is childbirth. So after childbirth. But I think sometimes we get limited in our scope of thinking about this to think only live births. And we should also be incorporating all pregnancy outcomes, including miscarriage, stillbirth, neonatal loss, right? And so this is something that can sometimes get missed. And so I want to put it on your radar that postpartum is any time after childbirth and delivery. Next slide. Now, how long is that time frame? I think that's an important question. So some places just define it more at 6 weeks. You know, historic maternal mortality metrics really only captured death up to 42 days postpartum, and that was missing quite a bit. Newer measures extend that to a year, but it really depends. I know certain employers only really count the postpartum up till 6 weeks. That's what you'll hear. And so that's interesting. There's a 12-week mark. That's kind of when we define it as the fourth trimester ends. Often that's when FMLA leave protection ends. And a lot of the international guidance defines it as the 12-week mark. Now, I included 12 months. I think anecdotally, if you talk to most moms, they will say, hey, I just didn't really feel like myself until about a year after baby. And I think that's something that we should capture. Also, Medicaid postpartum coverage lasts that year. And postpartum depression can persist beyond a year. 20% persist greater than a year, and 13% beyond 2 years, right? CHIP covers pregnancy visits plus 2 postpartum visits. So as you can see, there's kind of a lot of differing ideas about how long this period is. And so I think we need to not limit our scope in thinking that like, oh, she's at 6 weeks postpartum, I don't have to worry about this anymore, right? We need to extend our thinking broader than that timeline. Next slide. So what are some of those unique challenges? Well, I mean, there's the obvious ones like the physiological changes. Pregnancy is affecting major physiological changes throughout the body during pregnancy and postpartum, and that's going to affect mental health, right? A lot of those hormonal changes, lack of sleep, but also it's going to affect medication and how it affects. A lot of times medication is adjusted during pregnancy and then it has to be changed again in the postpartum period. So that's a lot to manage for these moms. Lactation challenges. Man, I think that this can be really big. Breast engorgement can be a big deal, but mastitis is one that we should highlight. I know I've had 3 babies and I never had issues with my first 2, but that third one, I got mastitis, I think 7 times. And it was really tough. And you're already exhausted and caring for other kids. And now you're running a fever and you feel like you're just doing a terrible job as a mom and you can't feed your baby, right? It's not just the physical problems with mastitis, it's also the mental toll that takes. And again, I think sometimes we see this in clinic as clinicians and it's like, oh, we prescribe an antibiotic and that's it. But going beyond that and saying, you know, Mom, how are you dealing with this? You're doing such a great job, and taking it to the next step. Also with mom, it's important to talk about the logistics and legal rights to milk expression if she's returning to work, talk through what pumping looks like. That can be a really big mental stress for moms, just cleaning all the equipment and things like that. Also talk to mom about fertility with lactation. And so as we all know, of course, you are less fertile typically when you're lactating, but you can still get pregnant. And there's a misconception that you absolutely can't. And so talking to moms like you can still get pregnant even though you're breastfeeding, and reminding them of that and having contraceptive discussions early on. Social challenges. So I added in here the 3-week mark for these social challenges because this is an area that I think gets missed a lot. So the 3-week mark is crucial because that is often when a lot of the resources and support systems that mom had are gone. So maybe their mom or sister, or someone came down to help for the first 2 weeks and they leave. Maybe their partner gets a couple weeks off of work. Now they're back at work. And so that 3-week mark, real life is setting in for this mom. Her support systems have left. Everyone's kind of going back to normal. The honeymoon period is kind of ended. And she's like, oh my goodness, what is going on? That's also not a time that we typically have postpartum visits, right? Usually those postpartum visits happen in that first week and then again at 6 weeks. And so it's kind of an isolating time. So I would encourage people to check in with your postpartum moms at that three-week mark. See how they're doing. See how they're adjusting to this new routine. Also, it's important to address birth trauma. That's a unique challenge to postpartum period. 50% of women perceive their childbirth experience as traumatic. 12% say it was significantly traumatic. And 4.7% developed childbirth-related post-traumatic stress disorder. And so I think it's important just as a baseline for all of our moms to give them the space to talk about their birth experience. Let them just share all the details. They just need to do that. But then also recognizing sometimes it's more than that, and we might need to refer to a higher level of care. They might need more if there is some PTSD going on from this. Also, pregnancy loss, trauma, and grief. There are approximately 5 million pregnancies in the US each year, with 20% ending in miscarriage. That is a lot, you guys, and they're processing through that a lot. So don't let that fall off the radar. Next slide. So going more into some mental health challenges specifically, kind of looking at the timeline, baby blues, we've all heard this, phrase, that affects about 70% of postpartum women in those first couple of weeks, and it's a real thing. Suicide risk, y'all, the second bullet point there, 86% after 6 weeks, right? So lots of times people check the box, they met their 6-week mark, we're done. That's where we need to expand our timeline here and have that ongoing screening. It's critical to capture these women. Postpartum psychosis, 50% of cases begin with the first 1 to 3 days postpartum, and 90% within the first 4 weeks. And then postpartum depression. That's a big one. 60% have pre-existing or antenatal depression, and 40% it's new onset after birth. And so it can be overwhelming to think through all of this. And so I think making sure you've got some good workflows and screening tools. PHQ-9 is something we're all familiar with, but getting familiar with the Edinburgh postnatal depression scale. So why does it matter what screening tool you use, right? For some very just practical reasons. So in the PHQ-9, it's going to ask some questions like, do you feel more tired or have little energy? Well, yes, they're a new mom up all night with a baby, okay? It might ask, has your appetite changed or are you overeating? Well, yes, they're probably nursing, and so they're going to be having appetite changes, right? And so that's going to skew the results of the PHQ-9. So that's why using the right test, using an Edinburgh that accounts for that is really important. And then using that GAD-7 to screen for anxiety. And then sleep, y'all, I can't harp on sleep enough and how important it is for their coping. And so talking about ways they can get more sleep, seeing if they are lactating, if they can pump once and have the partner or support person give 1 bottle and let them get like a 5-hour stretch, just trying to be creative with them and engage family and friends. And then talking through support. What support do they have? The other thing I wanted to talk about with support is this phenomenon that we sometimes see that's called maternal gatekeeping. And this is something I see quite a bit in clinic. And what it is, I think all of us can probably imagine this, it is that mom that has very high standards for herself. And she really primarily believes that she is the sole caretaker. The responsibility lies with her. And she wants to do everything right, which is wonderful, right? And we want to validate that. But also sometimes what it can result in is in there can be some control and monitoring behaviors with her support people. And she doesn't want really anyone else to help with the baby. Or maybe she starts micromanaging everyone that does and overcorrecting. And unfortunately, that criticism can lead to those support people saying, forget it, I don't want to help. Or they are too nervous to do anything. And so she is limiting how much support she can get. And so this is something that we commonly hear in clinic. You'll hear sentiments like this. And so when you hear that, lean into it and talk about that. Talk about her anxiety about other people caring for a baby. And one thing I typically do is I say, hey, let's try something. Let's just try it. And what it is essentially is some exposure and response prevention strategies. And the way I recommend this is I say, this evening when you're home, for 30 minutes, time yourself and don't give any criticism. Don't say anything. And the wonderful thing about babies, the thing they're best at is crying if they're unhappy. And so if your baby is really unhappy, they are going to cry. So we're going to let that other support person or that partner care for the baby, and you're not going to say anything except encouragement and see what happens. And typically, if they can practice this over time, they see, wow, my baby is okay with someone else caring for them. And it also gives confidence to that support person and lets them start to bond a little bit more with the baby. And so it's really a beautiful thing. So this is something we should assess with our support people. The other time I see this is in our teenage mamas, and maybe they're really young, 16 or 17, have had a baby, and it can happen the opposite way, that maybe grandma is helping and grandma is kind of micromanaging mom and telling her, and it makes it really hard for mom to start to bond with baby, and she's feeling like she's constantly criticized. And so talking about that when everyone's in the room, maybe talking to grandma separately and being like, hey, we really want to be able to strengthen your daughter's relationship with her new child. Let's do it in this way. Let's do some exposure and response prevention and talk through that. So it doesn't always happen just with the mom either. So something to be aware of. Next slide. All right. And so mental health challenges continued. We've talked about some of this, but I did want to highlight substance use related challenges because a lot of that we will see in that postpartum period. And patients with opioid use disorder, I have found in my clinic often miss their prenatal and postpartum visits because they really want to make sure that they get their medication. For me, it was buprenorphine. And it's great that they want to get their buprenorphine. The concern was that they were missing these other crucial visits. And so one thing we did in our clinic that really helped is we started to team up with some midwives that were in the same building as us, and we did some in-house training on how to do, for us, it was buprenorphine in our pregnant patients and postpartum and all of those things, and got the midwives to come shadow with us and got them feeling really confident. And then whenever one of our patients was pregnant, we would refer them over to the midwives that handled this specifically. And that way their visits for their buprenorphine refills and their prenatal visits were all at the same time. One visit. It saved mom a lot of extra appointments. It also made it more likely that she would actually come to those prenatal visits and actually get her buprenorphine. And then it was beautiful because that was often the same team that was delivering her baby, helping her with pain management at the hospital, and then who she followed up postpartum and already had that relationship with. And so more likely get her postpartum visits and her medications. And so I'd say if you're having a challenge, start to look at that. Is there anyone you can partner with that you can make these more consolidated visits? 22% of pregnancy-related deaths are due to substance use, suicide, and homicide, and that's a lot. And so here it kind of lays it out, 11% are due to substance overdose, 5% to suicide, and 5% to homicide. So that's why it is so important that we have these things on our radar and try to figure out low barrier ways to get them the help they need. There are a lot of screening tools out there, and so I listed some on the slide. I think as long as trying to work these into your typical workflows and do your universal screening can be really helpful. Having those stigma-free visits to help really understand what's going on in the house, screening for that intimate partner violence with trauma-informed and safety-centered approach, building that trust with your patients so they can be honest with you is really important. Next slide. So going back to some physical health challenges, really I like to kind of break this apart, and those first couple of weeks, that's when you've got a really high risk of those medical challenges, right? Those physical emergencies. And then in that 2 to 6 week mark, we move more into the recovery period, right? The physical and functional recovery, sexual recovery, and things like that. Also, depending on what culture your patient is a part of, there can be a confinement period at this time. It kind of varies depending on their culture. And so it transitions a little bit. And then that 6 to 12 month mark, there is a continued risk for cardiovascular disease and things like that that we need to be on the lookout for. And pregnancy-related mortality is the highest among American Indian, Alaskan Native, and Black women. So I think it is important to not, sometimes we can swing the pendulum one way or the other, right? We can only focus on the physical side or on the mental health, but really we need to marry the two and have all of them on our radar. Next slide. Awesome. So this is a lot. It's a lot to keep track of, and it can be overwhelming. So I have certainly been guilty of seeing that mom at like a 3-day postpartum visit, and especially earlier in my career, just completely overwhelming her with so much information and me wanting to make sure I didn't miss anything. And that's not great either. And so planning ahead is really crucial. So when they're doing those prenatal visits, you're planning for the postpartum stuff, right? You're discussing substance use, you're discussing mental health, you're maybe already providing some educational resources, getting a lot of anticipatory guidance on board, talk about their lactation expectations and what they're wanting. And then I think one of the best things you can do is ask mom, hey, what are you most worried about? What do you think could go wrong? And you'd be surprised what she might say. And that might really guide where you push into, because not everyone's going to have the same needs or same concerns. And so really tailoring this to the patient and figuring out what her needs are. Are they more mental health? Are they more physical? Are they more social, right? And starting to get your postpartum plan in place based on what she needs. And then check in at those key times. ACOG recommends that postpartum care be an ongoing thing, right? Not just a 6-week visit. Making sure you check in maybe that 3-week mark and again at the 12-week mark. And so we don't want to limit this time frame. The AAP advises pediatricians to also be screening moms because maybe they're coming in for their baby and not for themselves. So working your Edinburgh into those visits as well. Next slide. This is from ACOG. I'm not going to go over all of this, but I wanted to throw it up here as it kind of synthesizes a lot of what we've been talking about. So I recommend just kind of reading through this, seeing where your role in your clinic structure fits into this and what part you can lean into. We use Epic where I am, and you can make dot phrases and things like that. And so I think using something like that, like a checklist, and kind of doing all those prenatal visits, you're going through and checking all the boxes and making sure you assess each domain. So in the postpartum period, you kind of know what you need to go back to and follow up on. Next slide. And now I'm going to go over some supporting organizations for parents and some really good resources that all of us can utilize. And the first one, just staying on this slide, is your local library. So I put the Waco Library because that's where I live, but this is an often underutilized resource for moms. And so libraries are free, right? I think we can all thank Benjamin Franklin for that, right? And so this is a great place for mom to go and socialize. And they often do circle time and mommy and me classes. And they get keyed into other things in the community going on. It often helps with literacy, right? And so when it's safe for mom to go out with baby, I'm always like, have you gotten your baby a library card yet? Go to the library, get involved, see what they offer. And I find that it really, really helps them start to socialize and get around to other moms and young kiddos, and can be really helpful. And dads too. I love seeing all the dads at Circle Time. We're big on Circle Time. All right, next slide. Postpartum Support International is another great resource. They maintain a helpline that you can call or text for support and referrals to local resources, which is really cool. They have free online support groups that are led by trained facilitators where parents can connect with others that are experiencing similar challenges. They coordinate volunteer support coordinators around the country, and they offer actually offer training and certification programs for health professionals to improve their care during the perinatal, like for perinatal mood and anxiety disorders. They also have some really cool educational materials, webinars, and resources that you can use and have in your clinic space. So great resource. Next slide. Another good one is just good old HRSA, right? They do have a helpline that anyone can call, 1-833-TLC-MAMA. And so this is something you can put on discharge paperwork, right? So that moms have that resource. Next slide. The Motherhood Center, they have a ton of virtual groups for free, which is really neat. They offer postpartum support and emotional connection. They help process through those difficult birth experiences. So that would be one if, mom does really need to talk about that difficult birth experience and maybe you don't have 30 minutes. Being like, hey, here's someone that would love to hear your story and what you've been going through. Some of their groups also support dads and other partners. They're also LGBTQIA friendly for parents. And it's a great resource. It should be noted, though, these support groups are not treatment groups, and they do not take the place of individual clinical group therapy or medication management. But they do help connect these parents with other people going through similar experiences. Next slide. Nurse Family Partnership. Oh, y'all, I love Nurse Family Partnership. They did recently change their name to Change It. So we all have to get used to that for those of us that have worked with Nurse Family Partnership for a while. But they are a national organization. Their core goals are to connect first-time moms that are low income and their families with nurses. So they will connect first-time low-income moms and their families from their 28th week of pregnancy through their child's second birthday. That's over 2 years. It's amazing. And so they really get to know this nurse. They are there to offer support, answer a lot of questions. It's just really beautiful, the longevity in that. And, their real big aims are to improve pregnancy outcomes, enhance child health and development through education and support, and really just support families' long-term well-being. So really cool program you should look into. Next slide. Any baby can. So I apologize for all of you that are not in Central Texas because this is more of a Central Texas thing. But it's just such a great organization. I wanted to highlight it. They focus on family services and they're aimed at helping children succeed. And they really try to strengthen the entire family unit. Their work is really grounded in supporting child development, health, and overall family stability. They offer parent education, case management, therapy, care coordination. Their programs even can sometimes include home visits. Now that varies locally, as it's all a little bit different, but something for you to look into if you're in Central Texas. They also are not limited to only first-time moms, so that is nice. Next slide. Last, I couldn't not include the Leche League. I think sometimes we forget about them because they've been around so long, but they're so wonderful. And so helping support those moms that are lactating that maybe you don't have access to those wonderful lactation consultants where you are, but at least go ahead and supporting her to the Leche League can be really helpful. Next slide. And these are just some additional learning topics available that are on PeriPan that you can look into, dive into all these things a little bit deeper because I know it's a lot. All right, and that is it.
Thank you, Dr. Humphrey, for that presentation. We've had a few questions in the chat, which were promptly answered by our Hub team members. So thank you, Dr. Subrin, and thank you, Dr. Ruiz, for answering those questions. But I do want to allow some time for for additional questions. And if you have a question, you can type that into the chat or you can unmute your microphone and ask that aloud. We have had a request to go back to the resource page. Julio, is that something that you can put up on the screen once again?
Yes. Yeah.
Thank you. So some of the questions, while we wait for other questions to come up, were about screening tools for reproductive loss and also for culturally relevant screening tools. Those answers can be found in the chat.
Yeah, I had a question about the screening for reproductive loss. And, I've talked to several people. There is an organization called the Institute for Reproductive Loss who is coming up with a screening tool of 5 questions. It's not out yet, sometime now this year, 2026. But I work at a hospital system. And the question was, what screening tool are the nurses using for reproductive loss? And so right now they were using the Edinburgh, and I have said no to that. But I was just wondering if there is a screening tool that anyone is using. And I know this is grief, this is about grief, but if a hospital wants to have some type of screening tool implemented while they're here as a baseline, what would be recommended?
Hi, I'm going to take a first jab at this. It's such a good question. So typically, in my experience, I get called to the hospital very often for someone that had just experienced loss. And my experience, and I actually don't do any screening tool at this appointment because this is my general experience. Everyone's overwhelmed, and all of a sudden there's stigma from the patient themselves. Like, okay, I just had a loss. Now I have to see a psychiatrist. Like, now I have to fill this form out. I just had, like, it feels very, they're dissociating. They're just kind of, and then you got the mother and the family standing there, and they're saying things that is just not quite helpful. They're like, don't worry, you're young, you can have another baby. And so there's just so much stimulation going on for that mother. And then the father, it's going through their own loss. A lot of times they're also just, collapsing and they're trying to support each other. So it's a very hard situation. So I try to keep those appointments very short. I do not give any forms. I just say I'm here. And what I do give them is the PSI. I print out the Postpartum Support International. I say, here's a number. You can text and get connected to a coordinator. They have a huge loss support group. And I point out, I said, look, there's a free online support group for loss, just for loss. And they even separated there's early loss, late loss, or parenting after loss. So it's very specialized. It's moderated. So I just say, call me back let me know, and join the support group, call the maternal mental health hotline. And I keep it very short. And I ask them, if you want to, I can screen you or we can talk more. Would you like to? And often there's like, no, like, can we just like set an appointment for a month out? And so I said, okay, no problem. That's fine. But that's my general experience. I think a lot of mothers actually they get screen fatigue, and at the time it's very sensitive. And then often what I do is after a week, I do try to connect in a week, and I do go ahead and have them fill out the simple stuff, not too long, the PHQ-9 or the Edinburghs. By the way, those two are, you can just pick one or the other. They're both sensitive and specific. The Edinburghs originally is from Britain, so some of the language may be a little off. And so I personally prefer PHQ-9, but they're both equally sensitive. When you look at the scoring, they're both good. Pick one. I do the GAD-7, and I do a PTSD short screener. It is the PTSD-5, just 5 questions.
Mhm.
Avoidance is the number one predicament of PTSD development. Avoidance. In PTSD, we can't even diagnose it until 1 month pass. And so anything in that first month, I tell mothers this first month, you're going to have a lot of trauma response. Are we having avoidance? Are we avoiding the hospital? Are we avoiding people that are reminding us of the loss? That is a big telltale sign of the development of PTSD later. So we try to work on that. Okay, what can we do so that we're not avoiding now? And some mothers have such severe hypervigilance symptoms. I may start an alpha 2 adrenergic agonist in that first month if they're avoiding everything and avoiding their own family members. But often we like to wait and just see if it resolves, because 50% of trauma resolves without development into PTSD. So I do the PTSD-5. So these short screening tools are great because they're short. And
Mhm.
then I rely the rest on clinical interviewing. And so I hope that's helpful, but I'm curious if other people have any recommendations.
Excellent. Thank you.
Thank you, Dr. Ruiz. So you mentioned a few things about trauma, and additional like questions and motivational interviewing that I think is a perfect segue for our case presentation. And so, Dr. Zeitz, I think perhaps you might get a little bit more insight as we walk through this case that's going to be presented by Dr. Ganji. And so I know that there may be additional questions. I do want to ask Dr. Humphrey to monitor the chat for any additional questions that may come in as we review this case. But I do want to move on to our case presentation today. And so, Dr. Ganji, if you would please walk us through this case.
Absolutely. So hi everyone, my name is Dr. Ganji. I am a resident and I'm working with Dr. Ruiz for peri-pan psychiatry. So this case is very fitting for the echo session we're having today. It's a patient, she's 30 years old, and she has a history of substance use that kind of was ongoing throughout her history of life, but even during her pregnancies. And she really turned her life around after getting help, psychiatric help, being diagnosed with the correct diagnoses and being put on medications that were appropriate for her. So a little bit of background on this patient. She is 30 years old. She is currently about 11 months postpartum. But her psychiatric illnesses had started long before, stemming in childhood. She had a kind of background of having a mom who was a little bit neglectful, was suffering with alcohol use disorder. Patient herself started drinking alcohol at around age 15 to help her feel comfortable around others and to kind of soothe the emotional pain that she was having. And throughout life, this pattern of substance use, trying to use it for self-medicating for anxiety and depression and things like that, got to a head when she started using methamphetamines at age 16. And it actually helped her with staying away from the drinking. And so she was trying all these ways to kind of self-soothe and self-medicate. And she says that even when she started using methamphetamines back in her teenage years, she found that her focus was a lot better. She was able to clean her house. She was able to complete tasks. She was able to do all of these things that she wasn't able to do kind of on her own. Throughout life, around age 22, she did also have a stint with some opiate use disorder as well. And coming to kind of her late 20s, that's when she started having children. She's had a total of 2 children. With her first child, when she found out she was pregnant, she did stop substance use. However, the CPS had gotten involved and she did lose custody of that child. Thankfully to her mother, so she was still able to visit the child, but she couldn't, be the caregiver for the child. About a few years later, she got pregnant with her second child, and this was last year. So this was shortly before she came to us for treatment. And at that time too, she was able to quit her substance. She had relapsed in between the pregnancies. When she found out she was pregnant again, she had then stopped using the methamphetamines, alcohol. I think at the time it was just those 2 things. So she presented to us shortly after she had given birth in the postpartum period. And we had diagnosed her with depression and anxiety. And we had focused initially on getting her mood and anxiety stabilized, which is, as many of y'all probably know, the kind of hierarchy of how we treat our diagnoses in psychiatry. And so she was eventually stabilized on sertraline and sertraline 150, mirtazapine 7.5, and lamotrigine as a mood augmentation in the context of her MDD, PTSD, and GAD. But while a lot of those problems were solved and she started going 5 times a week to NA and AA meetings, and she had actually won custody of her kids back in the more recent months when I'd seen her. And so she was doing very well. She was actually leading some of these groups and helping others in her community with addiction issues. She had around October-ish of last year, she let us know that like while her mood and anxiety was good, she was still having a lot of trouble with focus, especially at work, and it was still disrupting her. And so we had sent her a DIVA form to fill out to evaluate her for ADHD. We did a clinical interview, and we felt that she fit the diagnosis for ADHD. So we started her on Vyvanse. Patient had a robust, good response to Vyvanse. It really helped her feel like she turned her life around. She was doing really well at work, continuing to lead these meetings. However, we ran into some issue with the sober living facility where she lives at. It's called The Haven. It's in Amarillo. But they had some pretty stringent rules about what kind of medications their inhabitants could be on. And we wanted to start her on something more similar to Adderall because we didn't want to disrupt her sleep and appetite, which, were some issues she was dealing with outside of that. But we were told that the only medication they would approve was Vyvanse. So which is why we went with the Vyvanse. And I mean, Vyvanse is a great medication. It's got that longer acting effect. When she had come back to us, she told us that it was working very great for her. There were some issues with kind of the end of the afternoon period. And so because the facility would not let us use anything besides Vyvanse, even though we had all this documentation and clinical interviews on notes showing that she had met criteria for ADHD, we were like, you know what? This is not typical standard practice, but we're willing to try Vyvanse twice a day if that's what it takes to help you. The facility turned that down and they wouldn't let us do that. And so I think we ended up just kind of sticking with the morning time dose. And she got some more skills from therapy and things like that. But it just kind of goes to show that this patient who, looking at her history, very clearly shows that she's had a history of ADHD, has struggled with ADHD for a long time. This stigma around this illness and the fact that this patient was someone who previously had a substance use history and they didn't want to give her a medication that could help even though she was indicated for it, definitely caused a lot of delay in care in her getting on the things that she needed to be on. So our consult question for the group was, where there's a lot of moments throughout her life where there could have been some intervention, some community resources that kind of came and stopped her from perhaps relapsing or, feeling like she was isolated and alone. So, kind of what do y'all think we could have done to prevent it from getting this bad?
And Dr. Ganji, could you update us on where the patient is at right now?
Yes. Yes. So most recently, back in December, the patient was doing so well, and her facility, they do regular UDS. And they know that this patient was on a psych medication, but for whatever reason, I'm not sure, again, was it stigma, what it was, but the facility had called the police and they brought up an old charge from years ago about child neglect. And it resulted with the patient being arrested and sent to jail. And it's been 2 months, almost, 2.5 months now, and she is still in jail. And this is really sad because this is a patient who had, on so many accounts, really done the work, not just meds, like counseling, doing all of the AA meetings. She really turned her life around. And if when you look up this patient on the, because the Lubbock County does post all of the charges on their Facebook page, you would see all her Facebook comments are all shocked because they're saying these are old charges, these don't apply, this patient has really turned her life around. But it just goes to show that people are so, or people can be so bogged down by things in the past that they're not willing to be flexible with their minds. And this stigma again is harming her so much. I mean, she's in jail now, even after having done all this work because of this. So
Yeah, and
Thank
I want to add that my heart just goes out to her children. I mean, think of the adverse childhood experiences that her two kids have already experienced. They're so young. They have been removed from their home and in different in so many different settings so many times. And so it just goes to show, transgenerational trauma, and we're witnessing it in her life and her children's life.
Yes, thank you for that. And thank you for that in-depth overview of the case today, Dr. Ganji. I want to encourage our participants to unmute their microphones or drop their questions into the chat. Or if there are any other insights, recommendations that you might have, you can either offer those aloud or in the chat too. I do see that Dr. Subrin put a couple of comments in here about stigma and about the ombudsman with the Department of Child Services.
Yes, I think I don't want to steal the room or the attention from our other, 87 guests in the room, but I felt the passion from your team of continuing to follow her case and continuing to fight for your knowledge versus what the Haven's awareness or policies might be. I've been up against that before. Where does the power lie? It's the physician recommendation versus the policy, and that's not right. And that's what got me thinking about the ombudsman. And in Arizona, it's called DCS. I think in Texas, it's it's still CPS, maybe Child Protective Services. So maybe think about filing a complaint, which of course takes months or years. So I think just being a voice, still popping in where appropriate to say, how's this patient doing? Has she been getting her meds? Like just that continued coordination will ensure, at least she's still getting it twice a day, which sounded atypical, but doable for what you needed to do. I
That's
just
such a
think that,
good
yeah, sorry, go ahead.
That's such a good point. I think it's such a hard thing because I know a lot of these facilities, and we're so grateful for because it's often private, and so we're so grateful that they have them. We we were grateful that they allow Vyvanse because I know some places don't even allow any medication, which I understand the philosophy, and I see the pros and cons, and I think in retrospect, honestly, if I could do something different, I probably would have reached out to Haven much sooner and just get everyone on the same page. And now we in the future we're definitely going to do that because they could have called us maybe, and kept us informed. So
That was my recommendation actually. I think most people are thinking that they're doing the right thing. I don't think they're out to get anybody. They truly think they're doing what they should be doing. And a lot of the times they just don't know. And so what I found is a face-to-face chat with somebody goes such long ways. It's so much better than an email or even a phone call. And so when I've had things like that where I'm like, okay, I'm hearing this is coming out of this sober living home or whatever it is, I'll just call them up and be like, hey, can we sit down and chat? This is a medication that I might be prescribing. This is what it does. What questions do you have about it? And I found that most of the time those meetings go extraordinarily well and decreases a lot of the stigma. And just to let them know, like, hey, I'm a reasonable human being. You can talk to me. I don't know. So that would be what I would do. If at the very inkling that there could be something starting to go askew and there could be some confusion here with the medication, just calling and being like, hey, can I come by tomorrow and bring some donuts with you? I get a lot done by bringing donuts places. So that'd be my recommendation. Donuts and a conversation.
Thank you, Dr. Humphrey. And again, we have plenty of space and time to allow other questions and comments. So please unmute your microphone and share your recommendations or comments aloud or drop those into the chat.
Just while people are thinking, I'll just say that, one huge success, it snowballs because we've all know like, oh, now you know the nurse at the Haven, right? Or now you know the clinical educator and like she knows you by name and you bought those donuts, right? Like you've made made a difference. So it does snowball because
the efforts made on the front end will help the next person. And this team that is sitting in front of me and that patient has incredible resilience. So.
Thank you, Dr. Subrin. Absolutely. Relationships are just so important, and people are more likely to listen to you and listen to your recommendations or even have those conversations when a relationship already exists. Dr. Ganji, you mentioned her incarceration. Do you have any insight about how long she might be there, and maybe where her children are currently?
I'm not sure how long she will be there. I know her children are with her mother right now. And her mom was the last one to contact us. And she had asked just to make sure that we would still be able to send refills, even if, she was in jail. And we had reassured her that absolutely, we don't want to stop treatment just because she's in jail. But that was over a month ago. So I actually have it on my list this week to reach out to mom because I haven't heard from her. But I do know patient is still in jail, unfortunately.
Mhm. And that's another barrier too. Often, even if you had the meds, you bring it to jail, it's not dispensed. It has to be on their formulary, and their team has to dispense. And I ran into this problem before where I had patients where they had a severe crisis, an episode, they're in jail without their meds, and it took just kind of days to get a hold of the right person, to get an assessment, to get them started on the mental health medication. So that sometimes that's another barrier.
Again, I'll kind of go back to my other point. This is something I encountered in Austin for our opioid use disorder patients and their buprenorphine. The jail wasn't doing buprenorphine. And so many of my patients were going to withdrawal and they were just miserable. And so I reached out to the medical director of the jail and we had coffee one day and talked through it. And it was like amazing. And within a couple of months, the jail is now doing buprenorphine maintenance therapy. And so sometimes it just takes talking to the leadership, talking to a group, and explaining things. And then once they realize they want to do that as well.
Thank you, Dr. Humphrey. I see all of the reactions to that comment. And yes, what a wonderful opportunity that everyone has to make those connections and possibly change policies or practices that are in different institutions that just are going to benefit patients overall. We have just a few more moments for questions, insight, recommendations, comments about this case presentation. Please feel free to unmute your microphone or drop those into the chat.
I just unmuted because sometimes it's just phrasing, like if you're the first person to ever write to the jail, maybe just sharing that email written by Dr. Humphrey or written by somebody else. Of course, changing with the blanks of like who you're writing. I do this with patients that need what we call, oh, I'm blanking on the name, but it's a humanitarian visa when people are coming through a border to visit a patient, and I just have a blank letter and I can send it to any port of entry. And this would maybe be one of those chances to create like a blank letter, like I'm trying to start a conversation about this, and my colleague in Texas wrote this, and I can borrow it, or it's just an idea. Phrasing is hard, so.
Yes, well, and that's what the ECHO community is about, is just sharing these resources and having access, and just the community of support, right? So Michelle De La Rosa asks a question in the chat. Has anyone offered information on the grandmother's rights? Or about the grandmother's rights.
Michelle, is this the case? Do you mind unmuting the
Hi. Yes, ma'am.
hi.
Hi. Yes, I was just curious on has anyone like offered the grandma anything about the grandma's rights program? You know, because I'm raising my grandson, and sometimes you know we're the only ones going through it. Uh, with the grandma rights program, I mean they offer lots of help for the grandparents as far as like because it is a hardship. So if you need like clothing. Um, any resources for potty training. I mean, they have that for the kids. So it's an amazing program. I was just wondering if anyone offered the grandmother anything, or maybe even check up on her because she's putting her life on hold to do this all over again.
Wow. Thank you for sharing. I haven't heard it personally, but I'm so glad you shared this with us, Michelle, because I know Dr. Ganji is going to reach out to this patient's the grandma this week, so we are going to pass this forward. I am just looking it up right now. Thank you so much for sharing
Yeah.
this, and we are, you know what, that grandma is going to have this information this week, so I appreciate you.
Even if it's like, I mean, you just tell them like, I'm in need of a few outfits for the summer. It's coming up, and they give you like a bag of clothes for the baby, for the kids. I mean, that helps a lot. It goes a long way because there's probably 2 to 3 babies, and it gets pricey. And they also help with diapers, pull-ups. If you need a potty train, a toilet for the baby, they help you. I mean, it's a really good program, and if your child has a disability, they give you resources to get you into the program, to get you early head start for the babies, and they also help you potty train the babies Monday through Friday. So I'm getting a lot of help with the Grandma's Rights program. I'm really grateful for that.
Is there a different name? I'm trying to find it because there's so
It's
many different ones.
it's it's called Grandma Rights.
Okay.
Um, program, yes. Um,
Okay, I'm gonna.
and it's like a little picture of a house and flowers. I mean, even the 211 can actually get you the information.
Mhm.
And right now I'm taking parenting just because everything is different today from when my children when they were small. And before I used to put the kids in timeout. Now I've learned to put their toys in timeout. It's totally different today. It's gentle parenting. It's amazing. It works. I have to say it works. And
Thank
there's also then I don't know if I'm going to say it right. The Narnon for uh, families dealing with families in recovery. Because when we're in recovery, when the child's in recovery, everyone's in recovery. Everyone who loves them.
thank you so much, Michelle,
You're welcome.
for sharing your experience with us. I believe that this has been a tremendous comment and help, especially for this case, and I'm sure for several other people who might be on this echo today. Dr. Subrin also puts kinship groups, respite groups, the KISS program in there as well. And it looks like Taylor McCain has dropped some links into the chat. So I encourage all of our ECHO participants to look at the chat and look at those links that have been dropped in. And I appreciate this conversation, but in the interest of time, we are going to move to some brief announcements. We will continue to take your comments and questions in the chat, which you can access by clicking on the speech bubble icon in the Zoom toolbar. In order to receive credit for today's session, all participants must have an active account with the Texas Tech University Health Sciences Center Office of Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that is provided in the chat or on the instructions on how to receive credit document that has been posted to the Content tab on iEcho. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation. If you have specific questions questions about CME credits, please email or call the TTU HSE CME office, and whose information is listed in the chat. You can scan the QR code, which is on the screen right now, or click on the link that's in the chat to complete the session evaluation, which will be available until 11:59 p.m. on April 2nd. If you already have your account set up with the TTU HSE CME office, you can use the text in attendance feature with the code 39941. This text attendance code is only available today until 11:59. Do you have a case, a difficult case like the one presented today that you or your team have encountered? Well, let's tackle it together. By bringing your challenging or complex case to the Maternal Health Echo, you'll get support from a team of experts and fellow providers. Now, there's no need to prepare a formal presentation. We'll provide a case form to fill out to assist with your case presentation. If you have a case presentation, you can email us at the email address that has been posted into the chat, which is cstat@uthscsa.edu. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at cstat.uthscsa.edu/contact us, and we'll be pleased to help you. And now I'll pass this presentation on to Jen Erdigy with the Peri-PAN program, who also has a few announcements for you.
Thanks, Brenda. I'm just going to give a real quick overview of Peri-PAN. So we are designed for clinicians who see pregnant and postpartum women. Peri-PAN was created to address the maternal mental health crisis. Mental health conditions are the most common complications of pregnancy, as you heard in this presentation. Mental health affects 1 in 5 perinatal women and is ranking among the leading causes of pregnancy-related deaths. So a lack of access to care and provider shortages further compound the problem. And as you can see on the screen, the Peri-PAN has 4 major components. We provide clinical guidance to help with single patient case or enhance mental health care in your practice as a whole. And then on the next slide, it should be a regional map of Peri-PAN. So we are anchored by 12 regional medical schools or health-related institutions across Texas. You sign up really easy and reach a mental health expert by phone, and you can consult with a reproductive psychiatrist within 30 minutes. Next slide. And we'd also love for you to join us for the Peri-PAN webinar series, which is held on the 3rd Tuesday of each month at noon Central Time. These webinars do complement the ECHO series. They just offer a deeper clinical insight and opportunities to learn directly from experts in the field. Next slide. And we just continue coming to these. This is a list of topics and dates for upcoming Lunchtime Maternal Mental Health ECHO series. They're held on the 1st Tuesday of the month. And I think I'm going to hand it back to you now, Brenda. Thank you.
Thank you, Jen. And before we wrap up, I welcome Dr. Subrin to provide our session summary and case recommendations.
Hi, everybody. Sorry, I did not know that was me. I think my main takeaway from the case is, don't be afraid to be the first one to mention a new protocol. Share your knowledge, your expertise, why you're making this impact, and it has a cascading effect. Continue to come to ECHOs where people's lived experiences and their professional experiences meet. That's amazing. Look for national resources and how they can impact wherever you're working. And that the whole family that is going through this, it's not just the mom, the whole family is going through this, not just the bio mom. I hope that was helpful.
That was perfect. Thank you, Dr. Subrin. And thank you, everyone, for joining today's Maternal Health Echo. And we extend our special appreciation to Dr. Humphrey for this wonderful presentation and to Dr. Ganji for her part in today's presentation as well. As a reminder, to earn CME credits, please complete the evaluation using the link that has been dropped into the chat. And if you have a case or scenario that you'd like to share, please email the CSTAT team at cstat@uthsc.sa.edu. We look forward to seeing all of you again at our next session on Tuesday, April 7th at 12 p.m. Central Standard Time. Thanks, everyone. Have a great rest of your day. Bye-bye.